failure is not an option.
I've had my ups and my downs.
Phelps with 10 meters left. 3 minutes too good. The crowd roaring. Freeman gets down.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Welcome to the Physical Performance Show, brought to you by Polar's world-leading GPS watches and heart rate monitors. I'm Brad Beer, sports and exercise physiotherapist by trade and training and founder of Pogo Physio. Each week we bring you the latest and greatest information and inspiration designed to help you perform at your physical best. Of course, we do this across a range of our different episodes: featured performers, learn-ins catch-up episodes, interest editions, expert editions, and coaches' corners. And off the back of our recent expert editions featuring Dr. Stephen Seiler on the concept of durability and Dr. Dan Plu's heart rate variability, today we keep the learn-ins coming your way with an expert edition featuring sport and exercise medicine physician Dr. Matt Hislop from Brisbane, Australia, discussing what we'd term a tricky condition, and that is the diagnosis of Popliteal Artery Entrapment Syndrome, PAES with the acronym. Now, like most tricky conditions, unfortunately, there can be a delay in diagnosis of Popliteal Artery Entrapment Syndrome. And for the suffering athlete, it can be very frustrating and limiting in terms of their running ability. So on today's episode and on episodes to come, we will feature some tricky conditions and put them in the spotlight in terms of their onset, risk factors, treatment, and management. And when it comes to looking at Popliteal Artery Entrapment Syndrome, today's guest, Dr. Matt Hislop, is a world-leading authority. Dr. Matt has a special interest in exertional leg pain, having published research on chronic exertional compartment syndrome and being one of the few practitioners in southeast Queensland who performs compartment pressure studies. Dr. Hislop is involved in research in the management of Popliteal Artery Entrapment Syndrome and has co-authored a number of chapters in the sports medicine equivalent of the Bible, Brukner and Kahn's Clinical Sports Medicine, on the very topic. He's been a practicing consultant sport and exercise medicine physician for the past 17 years, with coverage including the Chief Medical Officer for the Brisbane Broncos NRL, the Chief Medical Officer for the Queensland State of Origin Rugby League, the Brisbane International Tennis Tournament, and for Paddle Australia, Flatwater, Kayak and Canoeing, along with being a team physician with the Australian Olympic team. So let's explore this tricky condition with Dr. Matt Hislop, Popliteal Artery Entrapment Syndrome. Dr. Matt Hislop, welcome to the Physical Performance Show.
Thanks, Brad. Thanks for having me.
Dr. Matt, you are well published in this area we're discussing today. You're an expert in the field, a long history looking at exertional leg pain as a sports medicine and exercise physician. But Popliteal Artery Syndrome, can you enlighten us, PAES, what it is, and take us back as far as you need to bring us up to speed?
Yeah, look, I'll give you a bit of the backstory. I've got a long interest in exertional leg pain. I started off doing a master's degree looking at exertional compartment syndrome in the leg back in merry old Dublin in Ireland. And that sort of started a lifelong love affair, I guess, with exertional leg pain. You know, the leg's not as sexy as the knee or the ankle, but it's still a cause of a lot of problems and morbidity, particularly in running athletes who you and I see a lot of. So over the years, I've seen a lot of patients with unusual and tricky leg pain, and I was getting a lot of patients referred for consideration of compartment pressure testing. And when I looked at these patients, I thought it doesn't really add up. So there's a lot of crossovers between PAES and exertional compartment syndrome, but there's certainly a few features in their history that look a bit different. So when I looked at these patients, they had pain that would come on relatively quickly. The pain was more classically felt in the superficial posterior compartment or the calf. The pain could even come on at rest or be positional. So I thought this sounds like compartment syndrome, but it's not. So we looked at it a little more and we came across this condition called Popliteal Artery Entrapment Syndrome. So in this condition, the popliteal artery, as it runs behind the knee in the popliteal fossa, is being compressed or occluded. So when the person really wants to be getting blood and oxygen and nutrients to their calf, they're not. The variations in anatomy, which we'll discuss in a little while, lead to compression of the artery, and as a consequence, you don't get blood and oxygen and nutrients. And that can manifest as pain, it can manifest as tightness and fatigue, it can manifest as cramping, and even pins and needles or paresthesia in the foot, or any combination of the two. So the symptoms can come on fairly quickly with exercise, but also when they finish their exercise, they can resolve fairly quickly too. So the way I explain it, it's like having a garden hose and trying to water the garden, and someone comes behind you and kinks the hose. So you're not getting the flow whilst the compression is occurring, but then when it's released, the flow is re-established. So the symptoms resolve pretty quickly.
And that differs, Dr. Hislop, to chronic exertional compartment syndrome or exertional compartment syndrome in that the symptoms may persist after exercise has ceased for a bit longer as opposed to immediately ceasing.
Yeah, so as I said, there are a lot of crossover similar features between the two conditions, but with exertional compartment syndrome, because it's a build-up in the volume and the pressure, generally it takes longer for the symptoms to develop. And once they have developed, they take a lot longer to resolve completely. So we're talking minutes to hours rather than seconds to minutes for popliteal artery entrapment syndrome. Some other things that might make you consider the differences between the two. Exertional compartment syndrome is very uncommonly found purely in the calf. The superficial posterior compartment has such enormous capacity for expansion that isolated exertional compartment syndrome in the calf, I will always think popliteal artery entrapment syndrome first. However, if it's more in the anterior, lateral or deep posterior compartments, then, all bets are off and it could be exertional compartment syndrome.
So if it's symptoms are more at the front, if you like, of the leg or the anterior aspect, consider CECS or chronic exertional compartment syndrome. If it's more at the back posteriorly, query this PAES possible existence.
Now, the other issue is you can have both conditions present at once, which can muddy the waters even more. So my approach is always to identify the most likely cause and investigate that, see what's going on, treat that condition, and then you still might have other things to sort out at the end of all of that.
So work very systematically, one thing at a time.
For sure.
Matt, you mentioned the variations of anatomy that can produce these popliteal artery entrapment syndromes, which you've already shared around what they can be. What are the potential variations of anatomy that we may see?
All right. Well, look, I think it might be easy to go to the actual embryogenesis of the positioning of the muscles in the back of the leg. So on the screen here, we've got the development of and positioning of the muscles in the back of the leg when you're an embryo. So you can see at A here, we've got our popliteus muscle. We've got the original vestigial artery that runs deep to popliteus. And believe it or not, both heads of gastrocnemius originate on the lateral aspect of the knee. Okay? Now, over time, what happens is the medial head of gastrocnemius starts to migrate from the lateral aspect across to the medial aspect. Now, at the same time, the original primitive artery disappears from deep to popliteus and then reestablishes superficial to popliteus. Hopefully, by that time, the medial head of gastrocnemius has migrated across to its final resting position off the back of the medial condyle, and you've got your definitive popliteal artery sitting nicely between both the medial and lateral heads of gastroc. Now, unfortunately, sometimes that doesn't go according to plan. So there are two subtypes of popliteal artery entrapment syndrome. There's the type that's been termed anatomical. Now, it's called anatomical because there are fairly extreme versions of anatomy that lead to these types, and there are 6 that are described in the literature. So you can see here in type 1, what has happened is the medial head of gastroc has migrated across, but unfortunately it caught the popliteal artery and dragged it right across to the side of the knee. In type 2, it's similar, but there's this fibrous band that has surrounded the popliteal artery and it, in effect, is almost strangling it. In type 3, the artery has developed in the middle of the medial head of gastroc, so once again, it's sort of like constricting and tightening it. And in type 4, the original primitive popliteal artery never disappeared and it stayed running deep to popliteus. So these are examples of anatomical popliteal artery entrapment syndrome. They cause a much more severe type of compression and occlusion of the popliteal artery. Now, if these types are identified, we don't muck around. We send them straight to the vascular surgeon, and really the surgeon loves these sorts of patients because it's usually a bit of a cut, a bit of a switch around, and the patient's cured. So the patient's happy and the surgeon's happy. The other issue with not treating anatomical PAES is that patients will develop early onset damage to their popliteal artery. So in their 20s and 30s, they'll be looking at bypass graft if it's not sorted and treated. Now, the far more common subtype of popliteal artery entrapment syndrome is functional. Now, functional is still variations in the anatomy, but not as extreme as anatomical. So the naming is a bit confusing because we're still talking about differences in the anatomy, okay? But what happens in the functional type, and I've got my model of the knee here, so we're looking at the back of the knee. So I said to you, normally you'll have the popliteal artery running down between the 2 heads of gastrocnemius, and you'll have your 2 heads sitting where my fingers are there, okay? Now, in the functional type of popliteal artery entrapment syndrome, what happens is the medial head of gastrocnemius migrates across, but instead of finishing on the back of the medial condyle, it gets lazy and it stops halfway. So the anatomy is such that lateral head is in its normal position, but medial head is lateralized and sitting right where the artery wants to be. So in effect, you wind up with crowding of that popliteal fossa, and when people exercise, the muscle comes across and occludes the popliteal artery. So that explains the functional variation of popliteal artery entrapment syndrome.
And is that the 6 subtypes there, Dr. Matt?
The functional type is subtype number 6.
Okay.
So the functional type is much more common. We don't know the true incidence. The incidence of the rarer anatomical types is only in the order of, 0.5 to 3.5% as identified on dissection of cadavers. So that is far less common, but far more significant if it's identified. Now, to make things harder still, 50% of the normal population can occlude their popliteal artery with enough force of plantar flexion, right? 50% of us, if we put a Doppler ultrasound probe on the back of their leg and told them to push really hard against resistance, there'll be evidence of occlusion of the popliteal artery. So some people will argue that, well, that's a normal finding. But these people don't get exertional leg pain. So clearly it's not a concern to them. And we suspect that the force of plantar flexion required to cause occlusion of the popliteal artery is significant, okay? I had a patient who couldn't pass her driving test because every time she put her foot down on the pedal, she occluded her popliteal artery and got significant calf pain. So she was occluding her artery against little to no plantar flexion resistance. So that is far more significant than someone who will only occlude their popliteal artery pushing against, 3/4 of their maximal force.
So that's an important part of a patient's presenting history, I guess, Matt, is when are they getting symptoms with what activities, and if it's a lower threshold of like driving a car.
And some people get pain, laying in bed with their knee extended and their foot plantar flex. They start getting cramps and pain like that. And that's probably more significant. So, certainly more significant.
Yeah.
Tick all the boxes for functional popliteal artery entrapment syndrome. They need a good history. They need to have a good clinical examination. So I'll examine them in my rooms and we do a vascular provocation test in the clinic, and, they'll develop what's called a bruit with exertion and loss of peripheral pulses. And then they need to have confirmatory imaging, which is specialised Doppler ultrasound and MRI angiography. And standard vascular investigations, such as an ultrasound after running on a treadmill test, can potentially miss functional popliteal artery entrapment syndrome because, again, the way I explain it, they may be occluding the artery while they're running, but in the time they take to get off the treadmill, lay on the bed, put the probe on, the occlusion's not happening. So you need to image them at rest during provocation, so while they're pushing against the resistance and immediately after, if you're going to pick up cases of functional popliteal artery entrapment.
The imaging protocols have to be specific, Matt. It's you need a radiology team that can actually run the proper protocols for picking these up. It's not just general imaging.
Absolutely. And we've published protocols through a number of journals and radiology papers on the best way to approach that. And, I get calls from all around Australia and all around the world about, hey, can you talk through your protocols with our radiology clinic? And it's not standard claudicant leg pain investigations. You need to alter it a little bit. Ankle brachial indices may miss cases of functional popliteal artery entrapment because the occlusion occurs during contraction, which can artificially elevate that ankle systolic pressure.
You're listening to Dr. Matt Hislop, sports and exercise medicine physician, on this expert edition exploring the first of our tricky conditions series, Popliteal Artery Entrapment Syndrome. Support for today's show comes from Polar's world-leading GPS multi-sport and running watches and their heart rate monitors. Coming from the heart of the Nordics and with over 40 years of proven performance, Polar believe it all starts with heart. Their products give you the most accurate way to plan, train and recover. Polar's Precision Prime heart rate technology is the most accurate way to plan and track your activity and recovery 24/7, 365. Born in the Nordics to beautiful designs, Polar's watches are built to withstand the toughest conditions. Make sure you've got a stunning watch for any occasion. Polar's training load insights allow you to explore the limits of your body so you can find out if you are training just right to improve your performance and reduce injury. And with nightly recharge, you can truly understand and predict your recovery so that you can not only own the night, but win the day. So if you feel like it's time to beat your best, then jump across and shop Polar over at polar.com. Check out their all-new range. Support for today's show also comes from Earshots. Lock on, train on, and rock on with Earshots. They have you covered for staying motivated while you train. Their patented magnetic ear clip means you can push your limits without being distracted by annoying cords or earbuds that fall out. Use the code PERFORMANCE, all one word capital, at earshots.com for 10% off your purchase. That's performance over at earshots.com for 10% off your purchase. But for now, let's jump back with Dr. Matt Hislop, sports and exercise medicine physician, exploring this tricky condition, popliteal artery entrapment syndrome, the diagnosis and management of it.
Matt, any tips for practitioners in a room, whether that's colleagues of yours, sports medicine practitioners or sports physiotherapists, any golden tips you'd share via a physical examination aside from what you've already shared? Obviously there needs to be a higher level workup PAES is truly suspected?
Well, it's like anything, Brad. You need to listen to your patient. 9 times out of 10, you can almost make the diagnosis from the history. So if the patient says, and there's clues in their history that, yeah, I can get pain at rest, I've had it laying in bed, or no, I only really get it when I'm running long distances, and the location of the pain, concomitant symptoms, do the muscles feel hard or firm, which might lead more to a diagnosis of exertional compartment syndrome. So take a very good history. Again, I might share the screen and show you an excerpt of one of my papers that shows you clinical features that can help you distinguish between some of the more common causes of exertional leg pain. This is taken directly from one of my papers, and the common conditions are medial tibial stress syndrome, stress fractures, exertional compartment syndrome, and the 2 types of popliteal artery entrapment. Medial tibial stress syndrome, very common, and probably half of patients walking through your door will have some element of MTSS. And it's important to identify that and try and treat it and eliminate that and see what's left. Stress fractures, I know you've got a lot of knowledge in this area. They can be tricky. Sometimes they're quite obvious. They're palpable and they're sore and they're focal. But sometimes if they're buried deep under a lot of calf musculature, you might mistake it for a calf strain or a calf tear. But typically it's pain with impact. Exertional compartment syndrome, popliteal artery entrapment, they both present with what I call this pattern of crescendo, decrescendo pattern, all right? So typically when they're not exercising, they don't have a lot of pain. As they exercise, the pain builds up to a crescendo, and when they stop, they reduce over a similar crescendo. The rise and descent in popliteal artery entrapment syndrome is normally faster than what you see in exertional compartment syndrome. You can get hints from whether the symptoms are unilateral or bilateral. Typically, compartment syndrome, 95% of the time, will be bilateral. Stresses, as you know, typically unilateral. Popliteal artery entrapment syndrome, the functional type at least, is usually present in both legs, but the anatomical type may well be unilateral. So these are just a couple of hints that you can get from your history and your clinical examination. And then based on what you identify from those things, you should examine them. Examination at rest with both exertional compartment syndrome and popliteal artery entrapment syndrome, you may find nothing wrong. So you almost need then to bring on the symptoms. And that can be with compartment syndrome, getting them to go for a run, or with popliteal artery entrapment, I get them to do a series of 20 eccentric calf drops off the edge of a step. And then I'll auscultate the back of the popliteal fossa and check for peripheral pulses. So again, based on what you identify, then you make a call. Do we investigate with vascular investigations for PAES, or do we organise for a compartment pressure test? Which I do in my clinic.
And once again, that's a specialised protocol. It's the vascular testing on the PAES workup then. So if a diagnosis is confirmed off imaging, off these special protocols imaging-wise, what's the athlete practitioner's next best step?
If you identify the anatomical variant, which we've talked about, they go straight to, well, I'll start again. If we identify the anatomical variant of PAES, they go straight to the vascular surgeon. These patients do well from surgery. It's probably dangerous not to manage them and manage them early because they're at an earlier risk of development of atherosclerosis and damage to that popliteal artery. If it's a functional type, unfortunately, surgery for these patients is not as successful and can have as high as a 30% failure rate. The reason being is that, a good vascular surgeon will want to cure the patient, but also remove the minimal amount of muscle that is necessary to fix the patient. So it can be a little bit hit and miss when the patient's asleep on the table to know how much of a myotomy to perform. The good thing about surgery is that it does offer a potential cure, but it's always awful when a patient wakes up and their condition's not fixed, having gone through the surgery. This led myself and some colleagues to look at alternative interventions for functional popliteal artery entrapment syndrome. And what we came up with is Botox injections. So Botox has been around for a long time, predates the cosmetic guys by a long period. It's been used in managing cerebral palsy kids with spastic contractures. And effectively, it's a poison. It blocks the message at the neuromuscular junction and results in paralysis. When the Botox is injected to the muscle, that muscle that's injected basically cannot work. And the length or duration of action of the Botox is for about 3 months. Now, while the muscle is paralysed, it also shrinks and atrophies. So what we do with ultrasound is identify the muscles that are doing the occluding of the artery, and we inject Botox into those muscles. And typically that is into the medial head of gastrocnemius, and often additionally it's deep to a muscle called plantaris, which is a little more distal in the leg, but also seems to be involved in occluding of the popliteal artery. We've done follow-up studies of these patients, and we found 1 in 5 at 12 months were effectively cured. We found 1 in 5 at 12 months said, I don't think that did much for me at all. And we found 3 in 5 patients at the 12-month follow-up had noticed some improvement in their symptoms, which was starting to wear off somewhat. So that makes sense when you understand that the duration of action of Botox is 3 months, that we're also inducing atrophy of the muscle. And in some people, that atrophy is enough to cure them. In some people, it's enough to help them, but there can be some resolution of symptoms over time. Those patients may benefit from a top-up Botox injection. I've got one fellow who goes from being unable to run at all to, after the Botox, getting back to running ultra-endurance events. Now, the problem is over a year, 18 months, that muscle that we've paralysed and atrophied starts to hypertrophy again. So his symptoms can recur. That person is quite happy with the knowledge that he gets good relief from the Botox. He understands that, every 12, 18 months he may need a top-up, but he's still happier to do that than a surgery that is not guaranteed to fix him. Now, that 1 in 5 of patients that didn't get much relief at all, probably now our feeling is that rather than saying the Botox didn't work, the feeling is that maybe they needed more Botox, that their variation of anatomy was so significant that just one lot of treatment was not enough to make a difference.
Any limit to how many Botox procedures a sufferer can have over time, or is it just as per symptoms require in such an athlete?
Exactly. Botox is actually a very safe drug. It's very localised to where it's injected, and there's no limit, basically. What we did find with repeat treatments is that you are getting a little more atrophy each time. So it may be that after a certain number of treatments that patient is definitively cured, but we probably need longer term follow-up with that. The only downside really to the Botox is that in Australia at least, it's an expensive treatment and it can cost the patient a bit of money out of pocket. It's not reimbursed through the PBS, unfortunately. If Botox was a lot cheaper, then I think that it would be a treatment or an intervention that patients would take up a lot more happily.
So it's a barrier at the moment, the costs for some people.
That's right.
That's been a really great overview of a fairly intricate area and challenging condition. Return to sport, Matt. As a sports physio, listening to you talk about this, it's not very often that we wouldn't put a runner on some form of calf conditioning exercise, but I guess in populations such as true PAES suffering athletes suffering from the condition, purposefully trying to hypertrophy the plantar flexors or that region would be a contraindication.
I think you'll find they won't be able to do that sort of program because they'll develop pain fairly quickly. Yeah. So you'll weed those patients out pretty quickly.
Yeah, no, totally. Any other sort of adjunctive treatments, or you've covered the mainstays, Matt? The anatomical patients will proceed straight to surgery. And I was going to ask, is there any literature or observations from the your years in practice of how long it may take some people to get diagnosed, I think there's probably a lot of misdiagnosis around this. Would that be fair?
Oh, absolutely. Unfortunately, people will often put up and suffer with this for years and years and years before it's thought of or considered. And in fact, it wasn't that long ago, 10 years ago, that any cause of difficult exertional leg pain was just automatically assumed to be exertional compartment syndrome. And it's only when you listen to the patient and say, you're not ticking all these boxes, that you think outside the box. There's other rarer, more unusual causes of claudicant leg pain. You can get neurogenic claudication. So it's important to think of the more common ones, but it's also important sometimes to think outside the box. And that's why, over the years, I've come up with these protocols for investigation and treatment for popliteal artery entrapment syndrome. And I'm always looking out for weirder and less common causes of leg pain. I guess my next sort of project of interest is metabolic myopathies, and you touched on exertional rhabdomyolysis at the start of the talk, but they're certainly far less common, but can be a cause for exertional leg pain.
Matt, thank you. I think the first case I knowingly came across in clinical practice was maybe 10 or 12 years ago, and it's in the media, so it's a public interest case, but that was Shannon Eckstein, the surf lifesaving champion, who could compete across all short course events, but when it came to the Coolangatta Gold, which involved a long run leg at the end on soft sand, he would develop this claudicant leg pain with a few Ks to go and normally cost him the win.
Yeah.
And that was quite a well-publicised case, but is there any tangibility to people with greater calf muscle mass sometimes being people that more are prevalent to these claudication type conditions? Any correlation to that? The size of people's calves?
No, not necessarily. Obviously, big calves are visible to you and me when we look at the patient, but we're talking about variations of anatomy that are deep to what is more obvious from eyeballing the patient. And we're talking about particularly the position that medial head of gastrocnemius winds up in. So you can have enormous calves, and as long as that medial head of gastroc is attaching off the back of the femoral condyle, you'll be happy as Larry. You could have small calves, but if the bulk of it is running and sitting in that popliteal or trochlear groove where the popliteal artery is trying to run, then that patient potentially can get claudicant leg pain.
Okay, well, that's great. So no correlation to actually what we observe muscle mass-wise. Dr. Matt Hislop, there's many topics you could share around. This is just one of many of your expertise areas. But for the listeners or practitioners that may want to find out more about this particular area, you're based there at Brisbane Sports and Exercise Medicine Specialist alongside all your plethora of sporting duties. Where can people go to find you? The clinic?
Certainly, if you live in Southeast Queensland, your best bet is to come and see me direct. It's very... telehealth is good, but there's nothing like examining a patient and, being able to do a number of these tests and provocative manoeuvres. The hard thing with exertional leg pain is you typically need to reproduce their symptoms to know what's going on. So, yeah, we're based in Hawthorn on Brisbane South Side. We've got a nice clinic with free parking. So by all means, you'll find us, easiest bet to find us is on the internet, bsems.com.au.
bsems.com.au. We'll hook everything up in the show notes. Dr. Matt Hislop, thanks for sharing so generously at the end of an already big clinical day here on this Tricky Conditions series of the Physical Performance Show.
Thanks, Brad. Thanks for having me.
So there you have it, the first of our intermittent Tricky Conditions episodes. Thank you to Dr. Matt Hislop for his generous sharings around one of many of his expertise areas of sports medicine specialisation. Dr. Matt is available at Brisbane Sports and Exercise Medicine Specialist. Jump over to bsems.com.au. And you'll find Dr. Matthew Hislop's publications over on ResearchGate, or just jump across to physicalperformanceshow.com for the episode show notes. Now, massive thanks to our show patrons for their support of the show. You can become a patron of the show from just $5 per month, and in return, we'll grant you complimentary access to our back catalogue of live stream events: Dr. Shona Halson with Recovery, Dr. Stephen Seiler, Sustainable Training for Attainable Endurance Goals, and most recently, Dr. Seiler's 2022 live stream, Durability and High Intensity Repeatability for Endurance Training. It was another very successful event, and the good news at the time of this episode release, it is available for access post the live stream by jumping over to thephysicalperformanceshow.com and just click events. And a big shout out to our new patrons, David Percival, Shane Duffy, and Jason Mager. Thank you, gentlemen, for your support of the show. Keep the podsies coming. That's a screenshot of the episode you're enjoying and tagging in the show at Physical Performance Show over on socials. We'll reshare those, and they are always a whole lot of fun. And if you've been enjoying the show, then please consider leaving a rating and review over on iTunes. Massive thanks, as always, to the great folk who make this show possible each and every week: Daryl Misson, audio engineering; Susan Wilkin, show administration; Matthew Olding, show graphic design. Now you can find our video recordings over on YouTube. Jump over to The Physical Performance Show. Now, looking ahead, we have a smorgasbord of learnings coming your way, including an episode next week with core body temperature sensors, performance and tech lead Chris Blomfield-Brown. Core body temperature sensors are now being widely used across endurance sports, including by the powerhouse Norwegian triathlon team and the professional cycling peloton. So we'll learn from Chris next week regarding the ins and outs of core body temperature measurement and why it is so important. So until then, keep pursuing your physical best performance. I'm Brad Beer, and this has been The Physical Performance Show.